Hello everyone, thank you very much for joining us. We've got people joining all the time, so I'm just going to wait a few more minutes before we start. Hello everyone, thank you very much for joining us today. We've got people still joining, but I'm going to suggest we start now because I know time will get very tight as the hour wears on. So my name's Ellen O'Donoghue, I'm the CEO of James's Place, and I'm going to be joined today by Clare Milford Haven, our founder and trustee, by Jane Boland, our clinical lead, and by Dr. Pooja Saini from Liverpool John Moores University. So firstly, a few little points of housekeeping. I'll talk you through the timings for today in a moment. If I could ask you to remain on mute if you can. If you would like to ask any questions, please do. There is a Q&A function and we'll be checking that throughout so that we can keep track of all the questions. Please use that rather than the chat function so that we can keep all the questions together. We will be recording this session and we'll be hoping to share that recording on our website afterwards. So if there is any concern with that, please also let us know. So before we carry on, if I could just Dan, can you move the slides on? They're not moving on. Yeah. So we're going to talk through the findings from our evaluation. We will be sharing some of the methodology, some of what we have kind of seen and done over the past year. But we're going to start off by hearing from Clare Milford Haven, our founder and trustee, who will talk a little bit about the origins of the charity. Thank you very much.
We're having a slight slide issue, but hello everyone, and thank you so much for joining today. My name is Clare Milford Haven. I am founder and trustee of James's Place, and I am James's mum. I'd firstly like to thank also all the James's Place team for the incredible work that they do, both here in Liverpool and in London. As you can imagine, the intervention that we provide is very intense. The work that we do, the stories that we hear are extremely challenging, and I have huge respect for all our therapists for doing the work that they do. I would also like to thank Dr. Pooja Saini and the evaluation team. I've always felt that it was very important for us to collect the valuable data that we have so that our intervention is evidence-based. Today is a very big day for us as a result of that. But you'll hear more about that later, about the intervention from Ellen and Jane. So for me, it's hard to believe that we're now in the 4th year of operating this service. We have had over 1,000 referrals, and we've been able to help over 500 men. As a family, we always said that if we could save one person's life, then all of what happened back in December 2006, it would give it much more meaning, I suppose. So to have been able to help the amount of men that we have means so much to myself and to our family. And for me personally, it's amazing to witness a project that I held very much in my heart to now be a reality, and to be sitting here in Catherine Street today, sometimes it just seems unreal. James's Place was very much born out of reflecting on the very negative experience that James had when he was seeking help and was feeling acutely anxious following a minor operation in December 2006. Because of his experience, I wanted to create an environment that would welcome men, that would value and respect men when they came through the doors. I wanted to give them back the hope that they'd lost. And that's something that is really strong here. We do give back hope, and that is so important. And I wanted us to create a space that would be like no other space. No, it wasn't clinical. It was just warm and nurturing. And I think we've achieved that here at Catherine Street. So because of this, I was very concerned during lockdown that men wouldn't be able to come in here and they wouldn't be able to sort of feel the warmth that we provide here. And I was very concerned that we would be able to continue delivering our successful intervention with the restrictions that we had. As you're going to hear from our findings, that one of the top sort of triggers for suicidal ideation is relationship breakdown and family issues. And so obviously it was a huge concern about the challenge that would be posed for men who were at home, where they might have felt unsafe and where many of the problems lay, that they'd be at home and trying to have their therapy. But I'm happy to say that our therapists rose to the challenge and were very, very, very successful at delivering the therapy. Also, it was very challenging for the therapists. As you can imagine, they were having to work from home, they've got children, and they were having to talk about some very intense matters, from their own homes. So again, hats off to all of them who managed to achieve that. We're a very small charity, but we've got big ambitions, and we want to have an impact nationally. We're currently in a temporary space in London, and we plan to be in our permanent premises as of spring of next year. And our aim is to have 5 centres within the next 3 or 4 years. So we are so grateful to all of you for supporting us, for cheering us on in this great challenge. And again, thank you so much for being here. And I shall now hand over to Ellen to go into more detail about the evaluation, and I will be back to answer any questions later on. Thank you.
Thank you very much indeed, Claire. As Claire said, we're delighted to have people here today to share these findings with you. We're so pleased that so many of our colleagues and partners have been able to join us today, and indeed some of our own team. As you know, James's Place exists to save the lives of men in suicidal crisis, and we do this through a structured intervention delivered by professional trained therapists. And when Claire and Jane opened the first James's Place in Liverpool in 2018, it was a new idea. It was innovative, and it was a really important step forward in suicide prevention. And its very newness meant that it was particularly important that it be rigorously and independently evaluated from day one. So we've always been really delighted to work with Dr. Saini and her team at Liverpool John Moores University to do that. And a really important part of that work has been to pin down the model itself. And I'm delighted to be able to share that with you here today. You can see the model on screen now, and it's also a key part of the evaluation document, which I hope you will all have a chance to read. And what it really does is pin down our service in terms of a model of delivery. So in a kind of very top line summary, the men who come to us at James's Place will be assessed and assigned a trained therapist who he'll meet over around 6 weeks for approximately 8 face-to-face therapy sessions. And so what makes up that core intervention? Well, you can see at the heart is the intervention itself, as I say, based around face-to-face therapy in one of our centres, and using a set of cards called Lay Your Cards on the Table, which help men to articulate the distress that they're experiencing. It can be a big thing for the men that we see to even talk about how they're feeling, what they're thinking, and what they're doing. And the cards help them to do that. Next is the therapeutic environment, which Claire mentioned. You can see we're here in James's Place, Liverpool, and it's been designed to be a place where men will feel safe, will feel looked after from the moment that they walk in. And sometimes we talk about that being almost like having an additional therapist on staff, that by the time the man sits down for his therapy session, he'll already be feeling better and that he's somewhere that he's going to be taken care of. Next, our referral pathways and partners. It's really great to see a number of you on the call here today. And I think we've always designed the intervention to ensure that it doesn't replicate existing services, but instead works alongside them, making sure that men can find the care they need when they need it. Rapid access is a really important part of our work. We commit to seeing any man within 48 hours. It will usually be sooner than that. And we'll also make sure that one of our teams had an initial conversation with him as quickly as possible, so that he knows from his first contact with James's Place that he's going to find the help that he needs. And finally, our therapists. Claire's already mentioned the fantastic team of therapists we have who've just worked in such an impressive and dedicated way. And it's always been a core part of our intervention that we do work with trained professional therapists. The men we see are extremely vulnerable, and with our help, they can and they do get better. And to do that, we make sure that we employ people who are experienced counsellors, experienced mental health professionals, who are then trained to deliver our unique intervention, so that every man who comes to us will receive that same intervention. It's a work in constant progress. We're constantly, I suppose, building on it, defining it, adapting it, and we'll continue to work with our academic partners to do that. Before I move on to some of the results, I think it's impossible to talk about the period of this evaluation without talking about COVID. And I think that the model has been particularly important for us during COVID, because we've had to dig deep and interrogate everything that we do. Early on at the start of the pandemic, we briefly moved the entire intervention online, as Claire mentioned. That was for about 3 months. And what we realised was that it meant that we couldn't deliver one of the 5 elements. We couldn't see men in Catherine Street in our usual centre. But we could deliver everything else. We could see people quickly. We could maintain our referral partnerships, continue to work with our professional team and use the same intervention. So Jane, our clinical lead, will be talking later in this session, and she'll go into much more detail about that. But I did just want to mention the COVID timeline that she'll be sharing with you, that our Liverpool Centre manager Katya produced. It's an absolutely fantastic piece of work, and I think looking at it now almost takes me back there, and certainly should, I hope, give you a flavour of the time that we spent on a daily basis throughout that period, ensuring that we were able to continue offering our service safely to men at a very vulnerable point. And I think our focus on evaluation and data also meant that we were able to identify patterns and changes really early on. I think we were one of the first organisations to have evidence to show that men weren't coming to us through the usual pathways. They'd stopped coming to us through GPs and A&E, and instead were coming to us directly and through other routes. And that meant that we were able to find ways to reach those men directly and to help them find help when they reached out. And there is a statistically significant increase noted in the evaluation in self-referrals, meaning that men were finding their own way to get help during the crisis. So one of the things I think we're interested in to see is, what will the data look like in year 3? Will we see if this pattern continues, or will there be a shift in the way that men access the intervention again? So on to the headline findings. Having given you some of the context, I'm really, really pleased to be able to share some of these findings with you. And I think we were all really struck and really pleased to see that in year 2, the numbers are even better than in year 1 alone. And that's despite being delivered during a pandemic. So Pooja and Jane will talk to you a little bit about the core outcome model that we use, but fundamentally it's a numerical scale to identify the levels of distress that men are feeling. And what we see is that at the start of the intervention with us, we're seeing really high levels of distress, so in the kind of severe category. And during their treatment or their time at James's place, we're seeing a really significant drop of around 50 points. And that's an improvement, that's higher than we saw in year 1. And so in other words, during the second year evaluation, what we're seeing is men arriving with higher levels of distress and leaving with lower scores, indicating that they are feeling significantly better. So it's really key that as a sort of structured intervention, we're actually taking people with us from a place where they're really very vulnerable to a place where they are all, to all intents and purposes, feeling better and able to get on with our lives. So Dr. Saini will talk more about the intervention and also the academic evidence base behind it. We've been really pleased to be able to integrate the IMV model into our practice and use that kind of language when working with men to support the decision making that we make on a clinical basis with individuals. And what that means is that we can help them to understand how they've come to be in this crisis, how they can get through it, and how they can stop it from happening again. I'm now going to ask Dr. Saini to speak to you. I'll keep the screen on because I'm screen sharing, but please do flag if you have any trouble hearing her speak. Thank you.
Hi, thank you, Ellen and Claire. First of all, before I speak about the evaluation, I'd just like to thank the rest of the team as well at LJMU, Dr. Jen Chopra and Claire Hanlon, who've done a lot of work with us on producing the year 2 report. So it's a real pleasure to come here today and to speak about the evaluation and some of the findings that we got from the report this year. So the aims of our evaluation for year 2 were to look at the effectiveness of the model on reducing suicidality in men over a 2-year period, and also to do some comparisons between year 1 and year 2. We also wanted to have a look at the outcomes of men using the service pre and post the COVID-19 pandemic, and to see if there was any differences in how men use the service or their outcomes when they left. And finally, we wanted to gain some qualitative feedback from therapists about their experience of delivering the service pre and post COVID, just to ensure that we could take on board any learning and build on that to address suicidal crisis in the future as well. So we used 2 different methods, a mixed method approach when collecting the data. So we had quantitative data, which the service collates themselves. So that's part of their clinical system. And within that time, they have collected data on specific outcomes. So the core 34 clinical outcome measure was used in year 2. They also collected data on psychological variables as well, and some demographic data was collected from referral people when men arrive in the service. We used the online science software, SPSS software, to analyze the data. And we also collected qualitative data, which include in-depth interviews with the therapists working at James Place. That involves semi-structured interviews, and they took place throughout the pandemic period, really, since the onset of COVID. And we've always had participant and patient involvement with all of the work, from the design of the service to the research steering group, and also when we've been writing up some of our work and papers and publications as well. The study's gained ethical approval from Liverpool John Moores University, and we've gained ethical approval for the different aspects of the study along the way. So between 1st of August 2018 and 31st of July 2020, so that's a 2-year period, the service received 546 referrals, and they came from emergency departments, primary care, universities, the community, or through self-referrals. And we'll have a look later on how some of these referral rates have changed over the 2-year periods. So we had 76% of those men attending for the welcome assessment, and of those, 81% went on to engage in therapy. So for the people who did not attend the welcome assessment, some of the reasons we know of are simply that they didn't respond when they were followed up, or some were not feeling suicidal anymore when they were contacted from James's Place after their referral was sent through. So the mean age for the men attending the service was 34, and the mean number of sessions men attend was 6 sessions. So even though the service have kind of created a model that may include up to 9 sessions, we're finding actually the mean average of sessions is a little bit lower at 6. So just to go through some of the demographic characteristics for the men referred to James's Place, this hasn't really changed between over the couple of years, and we've not found any significant differences in the outcomes for the people or the men who are attending from different demographic backgrounds. I think the only unusual outcome we have here that we may not have expected initially when the service was opened was that we do have nearly an equal amount of men coming who are employed to unemployed. And I think the data and the literature usually says that people would be unemployed with some of the risk factors for men in a suicidal crisis. But actually what we're finding is that a lot of men in employment are attending the service and getting care for suicidal crisis as well. We've also got a high number of students attending the service. And again, we'll look at some of the differences in the rates between year 1 and 2 later on. In the year 2 report, we decided to have a look at the levels of deprivation for men using the service as well. So this isn't something we looked at in previous years, but we had all of the data to hand. So we thought we'd do a comparison. And what you can see here is that across all 3 years, we have 4 out of men attending the service who are from the most deprived areas. But when we did do a comparison between the men attending from more deprived areas and less deprived areas, we found that the outcomes were not significantly different. So the service is reaching men mostly from deprived areas, and most of the referrals are coming from men from deprived areas, but actually the outcomes for both groups of men are positive, and they have a reduction in their suicidal distress. So for the referrers, we found some differences between year 1 and 2. So we found in year 2 that we had a high level of referrals from secondary care, and actually the referral rate from primary care dropped. So we're not sure if that's to do with the pandemic as well, because that fell in part of year 2 or not. So this is something we're going to keep an eye on in future years. What we did see as well is a large increase of self-referrals of men. As you can see here, it's gone from 8 to 30% between year 1 and 2. And we've managed to collect a lot more data on where people are being referred from than we did in year 1, which is really positive. So when we're looking at the men's distress levels when they arrived in the service, we can see here that in both years, majority of the men were arriving in high levels of distress and scoring for high levels of distress on their core outcomes. But what we found is that in year 2, men were coming in higher levels of distress than they were in year 1, as Ellen spoke about before, but they were actually leaving in lower levels of distress. So we're unsure at the moment if some of those increased levels of distress are related to the situation that was going on with the pandemic or not. But what we can see is that the model is being really effective with the men, and we've actually had a larger shift in the difference in how high the severity score is and how low it is when they leave the service. So we've also looked at the factors, the precipitating factors that the men, that was provided to us by the referral services. So the people referring the men into the service would complete a form which would tell us about some of the reasons the men found themselves in a suicidal crisis. Some of these were completed by men themselves, and some were completed by the referral services that sent the forms. So we can see here, and Ellen alluded to this before, that relationship breakdown and family problems is one of the highest levels of precipitating factors that the men come with. But what we also found in year 2 is that there were other reasons for men finding themselves in a suicidal crisis, and they're the factors here that you can see with stars. They're new factors that we added in year 2 that were brought up by different people when men were referred into the service. If we can move on. Yep, thank you. So as Ellen spoke about before, a lot of the work we do is based on the IMV model, and the therapists are trained on using the IMV model when treating the men in the sessions. And they look at they have an objective view of the motivational and volitional factors, and they record these each time the men come for their sessions. So as we can see here, rumination is 90% and is one of the highest scoring psychological factors. We've also got past suicide and self-harm scoring high, thwarted belongingness, humiliation and entrapment, and an absence of positive future thinking. So these are not uncommon if you look at the literature, but we're actually looking at some of these aspects in more detail. So in year 3, we've started to collate more detail on entrapment. And also recently there was a paper published on a new scale, short 4-point scale for rumination as well, which we may also look at implementing in the service, especially as this seems to be a factor that affects a high level of men using the service. So I'm going to hand you over to Jane now, who will talk more about the model and the effects of the pandemic. Thank you.
Thank you very much, Pooja. I'm sure that you will have lots of questions for Pooja. Don't forget to put them in the Q&A as we're going along. So I'm going to talk to you a little bit about how we managed to keep going during the COVID pandemic. This slide is giving you a sort of a peek at our cards and the way that we structure our intervention. So I think if you sort of cast your minds back to the end of 2019 and the beginning of 2020, by March 2020, it looked increasingly likely that we were not going to be able to deliver our intervention in our centre, that we would have to go home. And our intervention is place-based. We've got a beautiful place here that we deliver our intervention in, and our intervention itself is very collaborative. It's very it's face-to-face, but it's often side-to-side. We use a pack of cards that we put on a table between either like the therapist and the man are sitting side by side or standing side by side, and we have the cards in front of us that we often move around together. So thinking about just how we would do that, and then thinking about how we would make be able to deliver anything, because it all happened so quickly. So if you look at this next slide, I'm starting to give you a sort of a taste of the timeline and sort of what we went through. So this first slide, the timeline, as Ellen mentioned, was put together by our centre manager in Liverpool, Katia, who became something of a sort of a guru for us on what was happening out in the big world in terms of COVID. She was sort of kept us incredibly up to date on all the latest sort of announcements, and she was scouring sort of guidelines for how we should be doing things. But this first slide is taking us just through March. So in the beginning of March, a COBRA meeting was held, and we started our sort of scenario planning. And by the 23rd of March, the Prime Minister then issued the stay-at-home order. The steps in between some of them were very practical. How would we how would we communicate with men? Could we deliver our intervention sort of over the phone? Did we have the tech, which we did? We're not a massively high-tech organisation, but our information system allowed for video calls. We gave all the team sort of phones so that they could take their laptops home. We use laptops, which was a decision we made at the beginning of when we started, which turned out quite sort of fortunate because everybody had a laptop. And you know, one of the two team members thought about how to put the cards onto paper. So we had sort of like quite a simple paper form, and another one of our comms colleagues at the time put them on a PowerPoint presentation, which allowed for them to be sort of manipulated a bit, and quite a nice way to share them with the men. We got all of our data collection on electronic forms within sort of that month. So the questionnaires that we sent out started. We'd done them on a piece of paper and gave them to the men. We now were sending them out electronically, which I think has probably improved our data collection longer term, but it wasn't something that we had necessarily thought about doing before we had to. If I go on to the next slide, this is really sort of us thinking about, you know, this was the stay-at-home period really for us. It took us through from towards the end of March, and our phased return to work, which happened at the beginning of July. And again, you know, have a good look at it when you get home, because some of the things that we had to think about, you know, changing the answer phone message, updating the website, making sure that all our referral partners knew that we were still here and that we were still delivering. So we were sort of quite active on social media, telling people that we are still here. We can still see you. We can't see you in our place, but we can still offer you help. We had to think about the well-being of the team who were all, as both Ellen and Claire talked about, we're now delivering an intervention to men in high levels of distress. You know, in my case, in the kitchen from the table. That was where I was working, as you know, as part of our family, which was, none of us had previously done any sort of work remotely or telephone work, or if we had, it had been sort of one-off phone calls as opposed to sort of actually delivering a therapeutic session, you know, and planning and running it. So it was all a very sort of different way of working. We started to sort of think about the return to work as we were watching sort of things like non-essential shops open. And again, some of the practical things around enhanced cleaning schedules and whether people would be prepared to come into the building, both staff members and men who wanted to use the service. Would it feel safe enough? And again, that to some extent, it feels like that's where the building came into its own, because I think that because our rooms are large, because they're well ventilated, we were able to feel that we were putting sort of robust mitigation factors in place that meant that we could use the building safely, that it was safe for us, and it was also safe for the gents who were coming through the door. And so by the sort of the beginning of July, we sort of had a process where men, where we started back in the building, and then from sort of the middle of July, like towards the end of July, I think we had this idea of phasing a return of face-to-face delivery. So at that point, so from the middle of July, we sort of early July, we'd gone from it was remote first. So all people would be offered a remote intervention, and towards the end of July, people were given the option of face-to-face if there were issues that meant that they couldn't access online therapy, or if we felt that the need indicated, like clinically indicated, that we needed to get them in the building. And that sort of flip from like, you know, remote to a sort of a hybrid to face-to-face first happened over that period. I mean, this timeline actually takes you sort of up to Christmas, but by the end of the evaluation period that we looked at, by the end of that, we were offering a face-to-face first service, and to some extent we still offer that. So the vast majority of men now access therapy in the building. or we're all here all the time. But for men who, for sort of COVID-related reasons, can't come into the building, we can still offer them the online intervention. And there have been a couple of occasions when therapists have had to stay at home as well because they've had to self-isolate or they've been poorly, and they've delivered it from homes. And I have to say, in all cases, people have the men using our service have just got on with it. And if we have had to make changes, they seem to have just rolled with them, really, and accepted that we're not in control of all of it. And sometimes those changes are just going to happen. So what did we sort of have a look at? So here we were in this situation, which you never would have done, but we had a situation where we had a pre and post COVID data set within this year 2 evaluation. And some of the sort of the headlines from that were that, nearly half of the men that we've seen altogether, sort of 47% of the men who we've seen in Liverpool since we started were actually seen during the pandemic period. And I think that reflects that the service started very slowly and small. I think the pre-COVID period, when we went back and had a look, was actually quite a low number. I think people were very worried and staying at home before it all hit. If my memory serves, that it was a very quiet January and February before everything sort of started really sort of ramping up. I think we were surprised to see a change in the age group of men coming during that pandemic period. So from and going from sort of 18 to 30-year-olds being sort of the main group of men coming to see us to sort of 30 plus. There was no significant differences related to any other sort of demographic factors. So, for example, sort of marital status, sexual orientation. So that sort of stayed the same across that time period. A bit of a change during with students. So very specifically during the pandemic, during that period, we saw a real drop off in students, which again sort of makes sense because most of them just went home. We did sort of work with our referral partners in the universities and with the GP, sort of the main GP practices that see students. And we did agree that we would offer our intervention while we were doing it remotely to students who weren't living in Liverpool but were based in Liverpool during term time. So we did want to, but our student numbers went right down. They are coming back up quite significantly now, though. And I think sort of a bit of a dig into the severity. We saw people who seemed to be more poorly during the pandemic than and during that lockdown period than not. They came in, actually I'm sort of, they came in sort of more distressed and they left better, and that was very heartening. So what did we learn? We learned loads, obviously. We learned that we were able to move quickly and effectively to remote working. I think the huge amount of sort of background work that went on from our admin team allowed so much of it to happen, but also the sort of the real the willingness to just give things a go by the clinical team, who were often sort of managing their own sort of issues around sort of living during a pandemic. A lot of our team have children, a lot of our team have caring responsibilities, and it was a difficult time for everyone. We are relatively low tech, but our tech did let us keep on working. I think we found the men using our service found the changes in provision acceptable, and they have gone on to find that the measures that we use in the building to mitigate risk acceptable. We've never had anybody who won't wear a mask, who, when we've asked them to, who hasn't agreed to health screenings. Overall, we identified that we can deliver our service remotely if all of the facets remain the same. So that's it from me. I'll be around for question and answers later, but I'm going to hand you back now to Ellen.
Thank you very much indeed, Jane. And so I really just wanted to finish off by talking a little bit about our plans for the future, and also some of the changes we've made at James's Place since the pandemic started. And I think there's a line in the evaluation report saying that, very clearly James's Place is making a life-changing difference to individuals, their families, the communities, and the wider system. And that's really motivating for us. And I think we could see that that was happening during the pandemic in Liverpool, and that made us really accelerate our plans to open in London. We opened a small virtual version of our service first. We've been absolutely delighted to be joined by Dan Bracken as our head of James's Place London, and he's been working with a team of absolutely brilliant new therapists, new recruits to James's Place to set up the service there. We're now seeing men face to face in London as well as Liverpool. We're in a temporary space in Clerkenwell while we work to open our permanent centre, which will be opening in the new year. And so this really gives us, I think, the stepping stone to open, or to go on to open, as Claire said, 3 more James's Places across the country over the next 4 years. And I think at that point, we will be achieving genuine national reach, so that men who need us will be able to access us and to find us. And that means changes for the way that we operate too, for the way that we take referrals. We've mentioned self-referrals a few times during this presentation, and that's an absolutely key part of our planning as we expand, as to how we can manage to make sure that the men who absolutely need James's Place can reach it, whilst we don't become overwhelmed by that level of need. So it's an exciting time for us. We're absolutely delighted to be able to share these findings with you, which I think really do show the impact of the work we're doing. And I think it's very clear we couldn't do what we do without the support of our partners, our colleagues, people like yourselves on this call, the amazing people who fundraise for us and who fund us. So thank you all very, very much indeed. We've now got a chance for some Q&A. I'm going to, Jane and Claire are actually going to use a different screen so that you can see as many people as possible. And we'll start with a question that I can see here about, were we surprised by any of the findings? And I think that's a really interesting and important question. I think there are things throughout the evaluation that are very striking to us, but I also think that because we are so close to our data, I think it would be very unusual for us to receive a report and to find there were things in there that we weren't expecting to see. And that was incredibly important during that period of enormous change at the start of the pandemic, because we could see things not exactly in real time, but pretty close to it. So almost a typical thing to happen would be our therapists would start noticing something anecdotally. They would say that men seem to be arriving with higher levels of distress. We could then look at some of the data that we were collecting at the core outcome data and see that that was being reflected in what we were seeing from a data perspective. And then as we kind of aggregate that going forwards, we could also begin to see that this is then being reflected in the overall findings, that it's not just the men who are coming in on an individual basis, but we can start to see that, yes, indeed, the core outcome scores are higher as we go through that period. So I think that's a really important and interesting point about the work that we do, that to some extent it's not that we'll be surprised by the evaluation findings itself, but we're constantly learning from those findings. I'm very interested, for example, in the number of men who we would identify as single or not cohabiting. We see high numbers there. We're seeing lots of things that I think we see at a granular level that are then reflected back at a national level and much more widely. And I think that will continue to be a core part of what we do. If I could ask a question to Pooja, if she's still on the call, how do you think this question just come in? How do you think this differs from other organisations' impact with this group, and what kind of commonalities are there also?
Well, I think firstly we need to highlight that there's a lot of differences with this service compared to some other services. And one, I think, really big difference is the rapid access. to the service and how quickly men can access this service. Like within 48 hours, they may be seen from a therapist. I think additionally, the environment that's been created at this service is, from what we've heard back from men with feedback when they've done comparisons between other places that they've received treatment or been referred to before, the environment is quite different at James's Place as well. So I think there's some real significant differences. Another difference is that the therapists are trained to be kind of, specialists in suicide prevention as well, and that's not always provided to staff working in services that are going to be seeing people in a suicidal crisis. So I think there's some significant differences in this service to other ones when we're doing some comparisons. Ellen, I was just wondering what the second part of the question was. So I know it was to do with the differences, which I pointed out.
It was also to do with the commonalities. So what impacts do you think James's Place shares with other organisations working in this field?
Well, I think the commonalities actually cross over more with the voluntary sector and the third sector rather than the NHS, and that's not necessarily a criticism on NHS services either. I think they're kind of very different in what they're doing, and it's the more holistic kind of treatment that's being offered, I think, within James's Place, and that it's in a community setting that has more commonality with some voluntary and third sector organisations, whereas the more medical kind of environments and models that are available within NHS settings, what we're finding is they're less suitable for many of the men who have tried those services before and have either ended up at James's Place after going to those services a few times, or even for the ones who've come for the first time, the environment seems to have played a real key factor.
Thank you very much, Pooja. That's really, really helpful. Can I just say to everybody, we're having a slight technical problem with the Q&A box. So if you do have questions, if you could copy them across into the chat as well, that would be really, really helpful. I can see a question in the chat actually from Peter Dickinson, which I would like to just address myself. What financial position is James's Place in order to open the next 3 centres? Where's the funding coming from? And there's an apology for missing that. And no, actually the apology is all mine for not having raised that earlier. So James's Place is entirely funded by charitable donations. We receive some funding from the CCG in Liverpool, but otherwise everything that we do is given to us by philanthropists, by trusts and foundations, and by the amazing people who do incredible things for us all, every day to raise money to support our work. So in terms of the financial position, we're now in a really good place for London and Liverpool. We have lots of local fundraising happening in Liverpool, and we have nearly, we're a little way off reaching our target to open our London centre. But to open our next 3 centres will be a massive task from a fundraising perspective. We were delighted to be joined by Amy Swart, our new head of development at James's Place, and she'll be spearheading a big new appeal in the new year to raise the funds to set up our next 3 centres. So I imagine that you will be hearing more from us in due course as we try to really, I suppose, celebrate the work that's already been done and recognise the work that's yet to come. Thank you. And I can see a question here, which actually I'd like to ask Jane to answer. So from Paul Aman, what can the wider city region do to support the continued positive journeys of men? Are there particular protective behaviours and actions we should encourage by employers and our education system? So Jane, can I ask you to start answering that one, please?
Yes, and thanks for that. I think that's a really good question, Paul. I genuinely think that suicide prevention needs a system-wide approach. I think when we talk about what James's Place does, we are, I'm sure some of you who know me have heard me answer it in this way before, suicide prevention is a big pie and James's Place is a relatively small slice of it. And the men that we see are coming to us in sort of a very acute place of need. in terms of the sort of the region and sort of employers and education systems, so much of that is about sort of well-being advice, about helping people to understand the impact of everyday stresses on their mental state. It's about good, you know, easy access to mental health care so that people don't get into crisis points. But it's having everything, isn't it, across the region. I think for employers, you probably, you know, I think there are different employers and different stresses, but it is about employee well-being, and it is about being a good employer, and having, you know, giving your the people who work for you ready access to mental health support, and making the decision to be an organisation that takes suicide prevention as a goal, that makes, you know, if you make cakes and you try and prevent suicide in your workplace by having positive workplace practices, by being able to talk openly to each other about mental health and about suicide, and knowing what resources are out there. So for the region, the Liverpool City region, I think it is, and we're lucky because I think we've got a very active region in terms of mental health awareness, but it's having that network across the region that so that men who were living in Knowsley or who were living in on the Wirral and Halton know that the Liverpool James's Place is as much for them as it is for the residents of Liverpool. It's a Liverpool, it's a Liverpool and it's a Northwest resource, and we want people to be able to use it. Is that helpful? Have I answered your question, Paul?
Thanks, Jane. I don't, Paul, can you answer us on the chat maybe? It's great, thanks, great. Thank you very much indeed. And we've got a lovely question from Mick Coyle, who's been a big supporter of ours. So thank you very much, congratulating another excellent year of results. And then a really interesting question for us, I think, which I would like to spend some time thinking about. So the report references a big increase in self-referrals. Is this a sign that talking with friends, family about the centre is more normalised and there's more community awareness of the incredible resource on the doorstep? I'd certainly like to ask both Jane and Claire to come in on this, because I think the kind of normalisation of help seeking is an incredibly important part of what we do. I'd also, I think, just like to say a few words about it myself at the start. I think we have had a lot to learn from opening a second centre in London that effectively replicates the model that we've already created in Liverpool. And one of the really, really key things that we've seen is that building that kind of support, that local support, that kind of, I suppose, normalisation of recognising that help is there is an enormous task. And it's something that I think we have been very, very lucky with in Liverpool. I think from the moment we started, which Claire can perhaps tell you a little bit more about, we saw enormous enthusiasm for our work in Liverpool. And I think that that kind of base of support does indeed help us to do our jobs, but I think it also helps men to seek help. I think there is a long way to go. I think there is still stigma around suicide, and I think we need to be really, really key that, you know, to get across that message. There's two things that you'd want anyone to know. It's that, you know, if people need help, help is out there, whether it's from James's Place, whether it's from one of our kind of many partners across Liverpool, London and beyond. You know, there is amazing help in the community. You know, people like Sean's Place doing fantastic work, the Samaritans, Shout, the Crisis Text Line, all of these are sources of help for people when they need them. And I think we really, really want to make sure that that normalisation does result in more help seeking. But Claire, can I ask you to come in at this point?
Yes, thank you, Ellen, and thank you, Mick, for asking the question. I think, as Ellen says, I think collaboration has a lot to do with it. So I think the fact that there are different services available, and so people can, to a certain extent, cherry pick now, which is sort of almost a luxury. I think Liverpool has always been very innovative. That's one of the reasons that I chose to come up here. I found Liverpool very innovative. I found Liverpool very, you know, very friendly, very engaged, and I think that I would say that this city is ahead of the curve to many other regions. I think that when we started our fund many years ago, before we actually started James's Place, but after James died, so which is nearly 15 years ago, people were still very, very reluctant to talk about mental health. They're very reluctant to speak about suicide. If it was spoken about, it was spoken about in hushed tones. I think there has been a huge shift in that, which is really healthy. It is a very, obviously, an incredibly difficult subject with lots of religious connotations, lots of stigma attached, taboo. And so it's very hard to get through all that sort of cultural and historical taboo and stigma. But I think that collaboratively with other charities that are working in this space, we are enabling people now to be a bit more open about these thoughts, which are very, very common, and sadly, but our belief here at James's Place is that suicide is entirely preventable. It is not an inevitable outcome to a crisis. It is preventable, and I think the more that we talk about it, the more we're open about it, the more everyone collaborates collectively, I think we'll make big changes. I don't know if Jane would like to say a few words as well.
As well, Jane and Claire swap over. Just say we've probably got about 5 minutes left for questions. So if you do have any more questions, please do pop them in the Q&A or the chat function and we can see them.
Yeah, I think in terms of the awareness that Mick's talking about, I think we've moved, even in the 4 years since that we've been here, that we've moved really massively in how we are able to get our message out, that you can talk to each other about suicide, that you can get help, and our most recent sort of outreach campaign that we did was, we were in the enviable position that we were able to get men who've used the service and men whose mates have used the service, or somebody whose dad used the service, to say, yeah, come, you can get help, it's fine. And I think that's starting to make a massive difference, and we're starting to see dividends being paid from being able to get that message out. So, suicide, sort of Claire was saying, it's gone from being a word that nobody dared to say to sort of something that was for the big boys and for hospitals and doctors, and it needed to be very, very medical. So actually, this is something that lots of people are the solution to this problem, that it's suicide.
Thank you very much, Jane and Claire. There's a really interesting question from Nick Lee. Hi, Nick, in the audience. On the issue about being open, and I'm going to ask Jane to answer this first. Do you offer men the chance to speak to each other, or is it very much between the person and their therapist? I don't know if you set up support groups with others in a similar situation. This is a very timely question, and I'm going to ask Jane. It is. It's very timely, Nick. Thank you very much. So when men come into us, they come into us at a crisis point, and the intervention is a one-to-one intervention with the therapist. But what we have identified is that some men, when they come to the end of their therapist, will benefit from some additional support. And sometimes that support can come from our mentors, so people who we've trained to continue to give a little bit of sort of encouragement and support. But also it can come from each other. So we have just started a peer support group and had our second one last night. We had planned to start it sort of before a year ago, but yes, so we do. We have a support group for men who've used the service. So it's very much peers and peers who've gone through James's Place. And in the new year, we will be having a group for people who are actually supporting men who are coming here as well. We offer one-to-one support for supporters. I'm saying support a lot now, but in the new year, we will be also able to offer some additional resources to those people whose loved ones are going through a suicidal crisis. So yeah, we recognise that we can do something that's not just one-to-one. However, primarily our intervention and our work will be almost sort of, we'll continue to really focus on the one-to-one stuff, because there are amazing groups and resources out there that do sort of group support, and we're really well linked in with those across the region. Thank you very much, Jane. So Amy and our brilliant communications manager, Dan Morgan, are helping us with the questions. So if I've missed any, I hope they'll flag it with me now. We're probably just getting to the 1:30 mark, so I'm going to wrap up unless there's anything burning that anybody has to say. Thank you so much for being with us today. I know an hour is a precious part of anyone's day, and we're really grateful to you for your interest and your support. Just to say thank you again, and we will look forward to sharing the Year 3 findings with you in due course. Oh, no, I'm just being told there's one more question. Okay, this is an important question too. What's the crossover or links with local NHS crisis teams? Jane, do you want to jump in and answer that, and then we will wrap up?
I'm going to sort of refer you back to the pie question a little bit, Hannah, and that we're very much focused on not duplicating what's already there. So we work really closely with the NHS partners, and we work in that sort of gap in provision of services. So the men that we work with are in that space where their mental health needs medically can be addressed by a primary care, but whose psychological and social crisis is pushing them into a suicidal crisis. And we work really closely with the crisis teams. They're so responsive to us, but both ways. I've seen somebody, but I think they're better with you, and we've seen somebody, and actually we think they need to come back to you because they need more than we can give them. And we work really closely with our GP providers as well. They're incredibly responsive to our requests for GP appointments and things. So I think we've slotted really nicely into the wider system, and have been accepted in that system in a way that blows me away sometimes, because sometimes we are a bit troublesome, I suppose, asking for things. And but I think that kind of commitment to want to save lives comes through in those times when we're having sort of conversations where we're asking for fast responses. But I guess that the fact that other people get a fast response from us helps make that relationship flow really well as well.
Lovely. Thank you very much, Jane. And thank you very much for all of your kind comments in the chat function as well. It really is, it's lovely when you're presenting to see these nice messages popping up. So thank you for your engagement, your questions and your time. I did just want to emphasise that James's Place is open for referrals in London and in Liverpool. If somebody needs our help, please do encourage them to reach out, to look at our website, jamesplace.org.uk, where there is a way of contacting us, a way of making a referral, but also a list of support for other people, for services that are beyond James's Place. So just to say thank you again very much indeed, and we will look forward to being in touch with you all again very soon. Thank you.
Thank you.